is really very difficult. And so having that sense of control is important. And I was very much struck when Catherine asked you the questions. Did they actually exercise their end of life option act? Did they utilize the medications? And the evidence actually shows that very often they don't.
Most of them don't. Most of them don't.
They don't.
And if you look at the data from Oregon,
Most of
it's
them
very,
don't.
it's most of them don't, but it's like, it ramps
0.3%.
up a bit as there's
Which is
more
right.
people using it, but
Right.
still.
So it's about this, that sense of control.
Mm-hmm.
And so from a population health standpoint, when you start to look at that palliative care population that's out there, and you think, what is most important to them, as we identified in that earlier discussion, it's about that sense of control, that ability to be engaged, that ability to have the scope to be a part of the discussion and the decision making. And you just identified again, on their terms. And so how does that translate into our evidence-based practice? We look at, in the service arena, those who work with palliative care, we look at outcomes that actually speak to percentage of deaths which were not in the hospital. Why? That's very aligned with personal goals. And then we look at our practice again and we say, so I'm the patient and I've said, or I'm the older person, I've said, no, I want to die on my terms. I really do not want to be ending up in an ICU and dying in the hospital. So that's my personal wish, my personal goal. How do we as a healthcare team meet that patient where they're at? Remembering that we have policies, interventions, rules, procedures, etc. It really is incumbent on us then to understand the relationship between the policies, the determinants, and how we actually achieve the outcomes that we want here.
And I think that's, speaking to that in particular, for all of us that have worked in hospitals, which I think we've all worked in hospitals, what we can bring to this is we know how the system works.
Right.
And we know what the laws are that compel us to do certain things unless there's something that tells us not to. And so
Right.
then we educate ourselves about pulse and we educate ourselves about all these things. And why would anyone know about any of that stuff unless they were a part of the system? They wouldn't.
Right. So,
And I
knowing
think
that those
too,
are the personal goals going.
If you didn't start with the personal goal and you went right to, if you try to jump right to advanced care planning and pulse, that gets sometimes misinterpreted as we don't want to take care of you, we're trying to shortcut your health care or something like that. And if you start with the personal goal and then go to, well, this is how we can achieve that goal.
How we execute.
But if you, when I do admissions, I have to ask every single patient, do you have an advance directive? Oh, what's an advance directive? Oh, that tells us, what your wishes are, and I start to explain it, and it doesn't always go over well, even if I feel like I'm explaining it well, because I have started with the end point, and I haven't talked to them about what they want. And then it's suspicious.
Definitely suspicious.
And then I send the chaplain, and then they're suspicious of, why am I sending the chaplain? I just got here.
Right. Exactly.
So I feel like the system sets up this dynamic of not addressing those things the way they should be addressed.
Right. And definitely we have room for improvement there. But it's also about that assessment of where is this patient at. So their understanding of you starting a conversation around advanced care planning and sending in your chaplain.
And I have to ask everybody,
yes,
whether you're 19
yes,
and have a fabulous prognosis, or if you're 99 and a no code. I have to ask everybody.
Right.
So there's no judgment call on my part how to approach that.
And you understand that clearly, but your client on the other side doesn't.
And they say,
So
why
that's
am
the
I
gap.
gonna die tomorrow?
Right. Exactly. So really interesting, good, very good example there. Great. Okay. Thank you. Do you have any questions either of you for Atu? No, okay.
Taps.
Are we supposed to tap?
Yeah, you can use
The tape works, I can make some tape with, I just don't know if we're supposed to poke holes in the wall.
Okay.
I'll get you another one. Comes from years of renting apartments and having to patch holes in walls.
So reusing Christmas ribbons, you know.
Yeah.
So Catherine and Catherine's task was to have a discussion
Yeah,
and
thank you.
present to us a little bit about,
Educational approaches and strategies.
sorry, I just lost a sneeze there.
Bless you.
Yes, educational approaches and strategies for this population, and I think they decided that they would choose a couple of areas and focus the discussion on
Areas
that.
that would need education
Mhm.
and strategies that we would use to educate these
Mhm.
patients. So the first one is medication safety, and one of the things that I've become aware of in my work in community health is that the majority of patients don't keep their medications in one spot. They're in various areas of the home. And in order to teach them, I really want them to have some hands-on. So I would have their caregiver or the patient or a family member get the medications all and put them on the table. And discuss each medication, and go over uses, actions, and the multiple names. That's always an eye-opener.
Right.
Some medications have 3 names, or 4. Some of the morphines have like 5 or 6 names. Side effects, and then we would write down each medication and some facts about it. And some patients have a list. I would want that list. I would want to update that list with them. Some of them have a counter, so it assess, what's going. And some patients will discontinue medication. They're not. Oh, I'm not taking that one anymore. 2 or 3 of them. Oh, okay, okay. So, we would talk about that. Maybe have to call a doctor.
What's a counter?
Their little
The weekly thing.
the weekly
The pill
thing,
box?
the pill,
Yeah.
with the
I've never heard it called
days
a
of the
counter
week.
before.
So update the list, look at the counter, see how efficiently they're, so there would be some dialogue, some hands-on, some written,
See them opening the container.
see if they
struggle
they're
with
able
that.
to open these things, open these containers, and are they still benefiting from medications? Or are they just taking them because a doctor told them to 5 years ago, and they're experiencing side effects, so the benefits, the side effects are worse than whatever benefit they're getting, so maybe we'll get those discontinued. So updating their medications and sort of in an interactive way with the patient, so they're learning at the same time, and being kind of a partner in their own care in that way. And knowing that they have choices and control. Not somebody told me to do this and I'm going to arbitrarily do it just because somebody told me to. And then emergency preparedness was another one that we would discuss some approaches and strategies.
So
on that.
my dad worked for PG&E, so this is like his big thing. One is the smoke detectors and the CO2 and making sure that the batteries are changed and and they're working, and then also knowing where the gas shutoff valve is and then marking it with like a bright piece of tape or some paint or something, and letting them know that if you do smell something, the safest thing is to turn it off, but then you'd have to call PG&E to come back out and turn it back on. But just to have that that adds to their independence, that they know, okay, I smell something, something's wrong, let me do this, and then having some type of phone access. Then what I was just thinking, cause in San Jose, we just had that big flood, so, are they in a flood zone? And if they are, do they have a plan? Do they know what the warnings are? And do they have access to something in which that they can receive those warnings so they know if they have to evacuate or not? And then Kathy was talking about patients who are on O2 but continue to smoke, and doing some education on that, and maybe having like a little sign for if they have visitors that don't smoke while the oxygen is being used. And she gave an example of somebody blowing out their wall because they wanted to smoke while on oxygen.
Yeah, continue. Some of them are compliant and some people are not compliant, and you'd be amazed. I see this often. People with oxygen in the home, and they're smokers, or the patient themselves is still smoking. Or they'll take it off and they'll go outside and smoke. But there are some that smoke while on oxygen. It's very flammable. Okay, so working with them on that, and not judge them, but it can be very dangerous. So then, we had another one. We were also discussing some safety issues and our educational approaches to the safety issues, which go along with some of the things on this poster about, the clutter, the home-based, things that we wrote out on our home-based safety assessment. Unsecured weapons is another one that we didn't come up with before. Is it well lit? Sort of in a non-judgmental way, maybe walking around and discussing these things in an interactive way, sort of developing a relationship, and making some suggestions would be my approach. A very non-confrontational, non-judgmental approach with people. Mentors, there may be a reason things are cluttered. Maybe they say, I know where everything is, So, as long as as long as they're safe in their own home, people have a right to live in messes and clutters, okay? I've worked with many social workers and they've explained this to me. You become concerned if there's a lot of clutter. People have a right to live that way though.
Excellent, thank you. So you already start to see kind of those connections. So you're talking about people having the right to live and die as they want. You're talking about people having a right to address their safety issues, their medication issues, etc. as they want. And so that as they want piece is really kind of foundational when you start to think about population health interventions, because you could design an intervention that's stellar, is wonderfully evidence-based, it checks all the boxes, but maybe the population may not want to use it for very many reasons. I think your example of the end-of-life option act is a great example of this. And you know what the debate has been and continues to be about it. But look at the behaviors around how elders are using it. They're using it perhaps to provide for themselves a sense of psychological comfort, knowing that, if I really had to, I've got a fallback. Many of them are not using it, but just the sense that I have access to this in and of itself seems to be more than half the journey down the road about, I know I can die at a time of my choosing, or if I'm at the point where someone may be trying to implement interventions that are inconsistent with my wishes, and that alone is hugely important to them. The other piece that I've heard threading through what you've been saying is the concept of teach back. Right. So we no longer go in and provide information and share, but we really want to do that whole evaluation piece, because it's the way in which we know that that information that was shared, that teaching and learning has actually happened, and that is going to be translated into whatever actions are needed, required, etc. Okay. Did you have a question, Liz? No? So that really brings us back to what you were discussing already. And so when you look at population health, we say it is holistic in that it seeks to reveal patterns and connections within and among multiple systems, and to develop approaches that respond to the needs of that population. And just this little exercise has demonstrated. So what's the common thread, the common pattern? The need for control.
To empower patients
Empowerment.
to have control over their own care,
Exactly.
to fear less and have more control.
And so as you continue to do the work around developing the toolkit and our satisfaction surveys and the curriculum for instructing the community health class, these are the concepts that's going to be absolutely critical in grounding that work, because that nurse that's going to be going out needs to understand that in this population, from a population health standpoint, given we've got a group of people with similar characteristics, they're over 65, they're chronically ill, X, Y, and Z, these are the foundational principles that you need to be aware of. So do outcomes matter? Well, you may do a brilliant surgery, well done, but the patient still died. So outcomes really, it matters. You know, it's not just about thinking of that wonderful intervention, but it's about thinking, well, how is that actually going to translate? And this is going to get us where we want to get to. Will it actually achieve something for that patient? So, shame the patient died. Wow. So let's look at the chronic care model.